So I had initially thought I would talk about the MAPP network, and I do have some slides at the end about that, but I thought, I changed things up slightly and really broadened the topic a bit, and these are the lessons that I would say I have learned from being involved in network science funded by the NIDDK. And this will be more of a talk about process and how the process goes, and I at least had fun putting it together. Hopefully you all enjoy it. So go over what these networks have been. So you're mostly younger in some of these. So there are networks that have finished. The Interstitial Cystitis Database Study, CPC was the Chronic Prostatitis Cohort Study, MTOPS was Medical Therapy of Prostate Symptoms. That did studies looking at different treatments for BPH. KMIS, Complementary and Alternative Medicine for Urologic Symptoms, the studies related to Saul Palmetto and others. The Interstitial Cystitis Collaborative Research Network did randomized trials for IC. The Chronic Prostatitis Collaborative Research Network did randomized trials for chronic prostatitis. The Urinary Incontinence Treatment Network conducted RCTs related to treatments for incontinence. The MAPP multidisciplinary approach to the study of chronic pelvic pain, that has officially ended. We don't have any more money. We're finishing up our last 2 papers, I think. And then ones that are current, the LEARN, which you've heard about, Symptoms of Lower Urinary Tract Dysfunction Research Network. Then the Pelvic Floor Disorders Network, which is actually funded by the NICHD, not the NIDDK. The PLUS Network, Prevention of Lower Urinary Tract Symptoms, and USDN, Urinary Stone Disease Research Network. I hope I didn't miss one. If I missed one, I'll be embarrassed. And the ones in asterisks are ones that I have been involved with in some form or the other. So I guess we feel like it gives me a little bit of street cred to talk about. So the way these work are the idea is that the NIH decides they want a group of investigators to study a certain disease. And it takes more money than a typical R01 because there are many sites. And it's also a little easier to get funding because they set aside money. And then they solicit, they announce an RFA, and then folks apply. And typically up front, they will say, this is a network to do randomized controlled trials, or this is a network to do a cohort study or a series of cohort studies. And those don't really intermix. So if it's a cohort study, you are not allowed to dictate the treatments, but you can observe outcomes, et cetera. And then they typically say there are usually about 6 clinical sites that will recruit patients, and a data core. And I think for this group, one important thing is some of the networks, there's a tissue core as well, where specimens are collected and processed in a certain way, and it gives a lot of good raw materials, if you will, for studies conducted, translational studies conducted, either by the network investigators or in the future by others. Now, how does this work? Well, everyone applies, and then, woohoo, you get a note, you got a grant, right? So then the NIH says, let's everyone meet in DC. And so then you meet, and it's a little smaller than this, the size of the meeting, but then you have the Duke table and the Northwestern table and the Michigan table and the Wisconsin table. And usually by that time, the NIH has asked someone to be the chair of the network, so that everyone finds out who that is. And the NIH will usually, the program officers will involve patient representatives, so then there's the patient representative table. And sometimes there are some ancillary sites as well to help with certain things. So you have your first meeting with all these people. Most don't know each other. No one knows what the other sites have proposed. You all have this grant. So then you have to share that info and figure it out. And so, sometimes it might be easy. Well, everyone just share their grants with everyone else. You don't want to do that, I find. It's like, I don't know, they're embarrassed about parts of it or they don't want to share their work product. But so part of that is building trust and getting to know each other. And typically You would arrange ahead of time. We'd like each study to give a summary of who your investigators are, what your team is, and what you're proposing. And then you have to figure out how you're going to turn that into a single unified protocol. And I've heard stories where sometimes, let's say it's randomized trials, eventually there's a secret voting process. It's maybe, and then whichever gets the most votes wins, and that's what the network is going to do. For cohort studies, it can be, I think, a little more tricky. I call it making sausage, and that's where the leadership group kind of has to identify, themes that seem to be the same across sites. And there are winners and losers. I mean, think about it, you've got a research team and you propose doing something, and you have someone who can do that for you, and then the response comes back, sorry, Charlie, we can't do that. Because the network decided we're going to do a little something different. So then what do you do with that? Those people who are on your grant now. Often they can be repurposed and still help, but it can be a somewhat difficult discussion. Then you have to develop a structure, a leadership team, and then kind of go about how often are we going to meet in person, video visits, procedures, etc. So it's a lot of work. You have to write the protocol. Someone has to roll up their sleeves and get the work done, and the DCC does a lot of this. Now, be aware that in these networks that I've been involved with anyway, most of the PIs, or really all of them, are urologists or urogynecologists, so they have a day job, and there's clinical pressures. There's seeing patients and operating, and so that can sometimes just make it harder to get this accomplished. And generally, as you might imagine, the people who do the most work reap the most benefits. And so there are good opportunities sometimes where, the PI is the well-known person, but then there's a more junior investigator who has the time and fire in their belly, and they do a lot of the work, and then that's how they make their reputation. And so then you develop aims and hypotheses. And there's usually an external board that reviews that and gives feedback, so then you have to take that feedback to account and adjust the protocol. Then get your IRB approval. And very importantly in this process, get your research coordinators involved, because they're going to help recruit the patients. Then you start recruitment, and at this point the research coordinators are the most important people in your team. And what always happens is recruitment never is quite what you hoped it would be. And some sites do better than others. And so then there's the conversation, meeting regularly. Well, let's talk about what you're doing at, Iowa. Iowa always recruits really well. The patients, I think, have a lot of allegiance to the University of Iowa. Sometimes the bigger city places don't recruit as well because it's hard for the patients to get in from fighting the traffic. Identify best practices. Are some sites paying more than others? Or how are they for the patients to be involved? Or how are they doing things? And then you get into discussion about maybe we need to modify things. Do we need to make it easier? Can we adjust factors? And that's pretty easy to do in a cohort study. But when you're doing RCT, you don't want to violate the principles of that. So So they started with pilot studies. The physical therapy worked great for men and women, but the men liked the massage too much. So in the pilot study, there was no signal that the active therapy was going to be better in men than the massage. So then they switched to a bigger trial, just of women, and proved that physical therapy was beneficial. So there you go, 57% response versus 21, pretty good. So that's the background to the MAPP. So then what we did in the MAPP is we recruited, it was 2 cohort studies. The first one, we followed the patients for a year and had them answer online questionnaires every 2 weeks. And the second, we followed them longer, for 3 years, and didn't bother them so often. But they were very willing to participate, I'll tell you that. We incorporated a lot of chronic pain research techniques that have been successful in other pain conditions, like functional MRI, like pain testing, where you put pressure, for instance, on the thumb bed, and there's then a tracing you get. Well, it's starting to hurt a little bit. Okay, no, don't, please stop. Sort of thing. And what you see in many patients, especially if they have widespread pain, they have more pain sensitivity there. And so these findings really push it away from this idea that these folks just have whatever, a syndrome, to maybe more of a disease model. So we developed better endpoints, pain symptoms, urinary symptoms track differently. Perhaps some treatments work better for one or the other, and if you ignore one component, you may not really get the full impact on your therapy. We developed a better scoring system for how to assess pelvic muscle tenderness. It's well known that that's important, but urologists tend to not look for it as much as they should. So we're trying to make it easier by having an easy scoring system. There's this prevalent feeling that these patients never get better. What we found, if we followed them 3 years, about 40% showed what seemed to be reasonable, clinically significant improvement, and it didn't seem to be a statistical phenomenon. And I think maybe most importantly, we showed that patients who have widespread pain, about a third of the patients, so they will have pelvic pain, but also they might have fibromyalgia or migraines or other type of chronic pain conditions. They're a bit different. The term for that in pain literature is nociplastic pain. They have unique MRI findings. They have evidence of systemic inflammation. And in a number of ways, looking back at some of the data from the trials and the data that we collected in MAPP, they seem to respond much better to systemic therapies, such as with amitriptyline. Those who just have pelvic symptoms do better with localized therapies like physical therapy or bladder installations. Now, the next step would be to do an RCT, because this is more secondary data analysis. And then, we were so excited that finally we've got the state-of-the-art group that we're going to discover biomarkers or some type of microbiome or something that lets us say we can do a urine test and with some degree of reliability identify patients with chronic C. Didn't happen. There unfortunately is, there's some potential, markers that suggest inflammation, etc. But the fact is there's no H. pylori for interstitial cystitis as much as we'd like to. So I think it's fair to say the MAPP was the most comprehensive study of IC and chronic prostatitis to date. And we have all of this information, some of which I didn't talk about much at all. And we've spent a fair bit of effort to have this in a user-friendly format at the NIDDK repository. And maybe just as importantly, on the MAPP website, there's a way so that if someone has an idea and they say, let's look at how many patients in MAPP with a diagnosis of IC who's a woman had this data available, you can do that to make sure that it's feasible for the studies that you might want to do. With the goal of, hopefully, what we've done in MAPP is just the tip of the iceberg, and what you all will do in the future is much more important. So, hope I didn't go over too far. Thanks for your attention.